Hello, I'm Dr. Marcia Brose, Director of the Thyroid Cancer Therapeutics Program and the Center for Rare Cancers and Personalized Therapy at the Abramson Cancer Center. I'm a professor of otorhinolaryngology, head and neck surgery, and a professor of medicine in hematology and oncology at the University of Pennsylvania. Welcome to this peer review in motion activity entitled A Visual Exploration of New Opportunities in Thyroid Cancer, Targeting RET Alterations to Optimize Outcomes. In this educational program, we will use dynamic infographic visualization and animations to learn about RET fusions and mutations relevant in different types of thyroid cancer, the increasing importance of genomic testing to identify these alterations, and the new clinical role of RET inhibition in the treatment of thyroid malignancies. So when we look at thyroid cancer, the clinical presentation and diagnostic classification is based on the cell of origin. So differentiated thyroid cancers originate from follicular cells and include well-differentiated subtypes including papillary, follicular, Hürthle cell, and poorly differentiated and undifferentiated anaplastic cancers. Thyroid tumors originating in parafollicular C cells are categorized as medullary thyroid cancer. When we look at the genomics of thyroid cancer, what's interesting is how many of these cancers can be attributed to kinase mutations or fusions, and interestingly, how many of them actually are targetable at this point. So now let's turn our attention to the function and biology of RET. RET encodes a receptor tyrosine kinase, RTK, that contains a large extracellular domain, a transmembrane domain, and an intracellular tyrosine kinase domain. And here's an example of what it looks like with the domains shown on the schematic. So we know for a fact that RET is activated in cancer through chromosomal rearrangements that generate fusion genes containing the RET domain, and this is the predominant type of RET alteration in both lung cancer and in differentiated thyroid cancer. But we can also have gain-of-function or missense mutations, and this is actually the primary alterations that are seen in medullary thyroid cancer. If you look, you can actually see the different types of codon mutations in this case of medullary thyroid cancer that are altered, and you can see that vast majority of them tend to be the M918T. However, there are still many others that are found in RET-altered medullary thyroid cancer. RET is activated by two main mechanisms in thyroid cancer. 40% of medullary thyroid cancers may be associated with a RET mutation, and in the case of hereditary, all of them are associated with RET mutations, and in sporadic, up to 60% can be altered with RET mutations. And we also have RET fusions, which are more common in the differentiated thyroid cancers, in approximately 10 to 20%. In both cases, these alterations result in constitutive activation of RET. So either because it's turned on the kinase domain automatically, or whether it's because it's dimerized to another regulatory portion of a different gene, in both cases it results in upregulation of RET. So oncogenic RET signaling and RET inhibitors are important because if you have the mutant RET at the cell surface, you're going to have basically ongoing signaling through the RET receptor, and that results in tumor growth and proliferation. And not only through the receptor, but of course through the fusion, that it doesn't even need to be localized anymore to the cell surface. This results in unbridled tumor growth and proliferation, and I'll point out that it's likely the cause of the cancer. So whether it's because of a fusion or in the case of a point mutation and you have ongoing RET that's causing the cancer, most likely these tumors will exhibit what we would call oncogene dependence. In other words, this is why the cancer became a cancer. It's the mechanism that's maintaining the cancer, and if you actually inhibit it, you can stop tumor growth and proliferation. This is the beauty of being able to target and know the causal mutation for these cancers. Now you can actually target them directly and take care of the patient and decrease the growth of the tumor. So currently we have two highly specific RET inhibitors that have recently come on the scene. Historically, I'll just point out that our first generation RET inhibitors were not specific to RET. There's alectinib, cabozantinib, lenvatinib, and vendetinib. And actually for medullary thyroid cancer, cabozantinib and vendetinib are the two that are currently FDA approved in this setting. Now, the new ones that are coming out are highly specific for RET, and they include selpercatinib, which is illustrated here on the left kinome, and pralsetinib, which is on the right. And what you can see from these kinomes, especially if you've ever seen the ones for cabozantinib or lenvatinib or any of the other kinase inhibitors, is that these are incredibly specific inhibitors. They really hit their main target, which is RET, and very few other targets. So interestingly, RET is very closely related to VEGFR2, and that is part of the reason why cabozantinib and vandetanib, while also being VEGF receptor 2 inhibitors, also inhibited RET. But in this case now, we have the development of two very specific RET inhibitors that do not target the VEGF receptor as much and are really much more specific to the RET molecule alone. However, there's also a little bit of activity of pralsetinib on other related kinases. So now let's talk about selpercatinib because it is a potent and selective RET inhibitor. When it was originally studied in xenograft models, you can see that compared to cabozantinib, LOXO-292, which was actually the name prior to it being called selpercatinib, was very active. In the vehicle, we had unbridled growth. We had some inhibition with specific mutations, mostly the KIF5B RET translocation, but with LOXO-292, you had across-the-board pan-RET inhibition of translocations. For that reason, there was great excitement to develop this further in this setting. In the orthotopic brain model, you can actually see that treating patients who had the CCD6 RET translocation resulted in ongoing longevity of the patients versus early death that is shown here in the black and the red curves. So while ponatinib, which is another RET inhibitor, could help somewhat, we actually can see really nice continued survival of the mice when they're treated with selpercatinib. So this was the preclinical information that led to the excitement and the interest in moving forward with phase 1 and phase 2 clinical trials. So Libretto 001 was basically a phase 1 and phase 2 clinical trial to look specifically at whether or not RET-mutant medullary thyroid cancer and RET-fusion thyroid cancer, as well as RET-fusion-positive non-small cell lung cancer, would benefit from treatment with selpercatinib. And of course, as all phase 1 clinical trials do, we're also looking for toxicity and tolerability first, and then once we can see whether it's not as tolerable, we wanted to know how active was it in these settings. Patients were allowed to have prior cabozantinib or vandetanib, but also a good number of them were cabozantinib and vandetanib naive. And this was important to understand what was the activity of selpercatinib in the first-line setting. The primary analysis set included 55 patients, the first 55 patients with RET-mutant medullary thyroid cancer who had received prior cabozantinib and/or vandetanib. So this is the primary analysis set, sometimes shortened as PAS. In these cases, all RET alterations have been determined by a local CLIA or similarly accredited laboratory. The primary endpoint was the objective response rate using RECIST 1.1, and the secondary endpoints included duration of response, progression-free survival, and safety. And in some cases, treatment beyond progression were permitted if it was felt by the investigator that the patient was continuing to benefit from the drug. In those cases, most of the time it was because there might have been a solitary site of progression, and that could be taken care of with either surgery or radiation, and then the patient could continue to benefit in other areas by continued treatment with selpercatinib. So let's turn now to look at the results from this primary analysis set. Selpercatinib efficacy summary was published recently in the New England Journal of Medicine. And the key takeaway of this entire study is the fact that the overall response rate was so good. If we look at RET-mutant medullary thyroid cancer that was previously treated, we can see that 69% of the patients had an objective response. And this is very close to the investigator assessment, which was 62%. If we look at RET-mutant medullary thyroid cancer that was not previously treated, we see that the overall response rate goes up to 73%. And finally, when we look at previously treated RET fusion-positive thyroid cancer, this would be the differentiated thyroid cancer cohort, the overall response rate was 79%. This is really quite remarkable and is in the same league as the phase 3 results of some of the other VEGF receptor inhibitors that were active also, if not exceeding them. When we look at it, we see that most of these were partial responses, but several of them were also complete responses. But look below at the line for stable disease. You see that another 14 patients in the previously treated cohort, or another 25% of patients, also had stable disease. 20% in the case of the RET mutant not previously treated had stable disease, and another 21% in RET-treated fusion-positive thyroid cancer. What this means is that the vast majority of patients were getting a clinical benefit, stable disease being patients who maybe did not meet the 30% cut, but their disease stabilized with maybe a little bit less shrinkage than 30%. So overall, it's clear we have a very active agent on our hands, and this is what we would have predicted given both the preclinical data and the rationale for targeting RET to begin with. Now let's just focus in a little bit more on the data for medullary thyroid cancer. So now let's turn to the waterfall plot from the New England Journal of Medicine paper that was recently published. The vandetanib and cabozantinib, as well as the patients that were treated with both, were all equally likely to benefit from treatment with selpercatinib. And you can see that it didn't seem to matter what prior therapy they had had. They all seemed to do quite well with a good overall response rate, and most of them still exceeding the 30% cutoff for a partial response. The full responses are shown on the right. When we look further at the patients who had not received prior kinase inhibitor therapy, the responses look even better, with even more patients achieving the 30% shrinkage that we have seen in the numbers in the prior tables. I don't think you can mistake the fact that even the patients who have not passed the 30% criteria have still also had significant shrinkage. So virtually every patient who's been treated with this therapy, with the exception of maybe one patient, seems to have had some type of shrinkage. I also question whether or not, if these patients had been followed further out, if some of those patients with less than 30% might have eventually had more than 30% down the line. But at least at the time of the data cutoff, it's clear that a large majority of patients are exceeding the 30%. This shows what is the duration of response and progression-free survival for the patients who had been previously treated. And on the left, you can see the median duration of response had not been reached. But on the right, you can see with progression-free survival that patients did really quite well, and the progression-free survival is out over 2 years. This is, of course, in addition to the fact that we have really good responses, it's very important to our patients to see that this response is durable. And so for medullary thyroid cancer, a drug that shrinks the tumor and then lasts for over 2 years, when we're talking about metastatic patients, is certainly a win, and was definitely a win for all of our patients who were treated with this agent.
In patients with RET-mutant medullary thyroid cancer not previously treated with vandetanib or cabozantinib, the median duration of response was 22 months, and the median progression-free survival was 23.6 months.
And let me just show you the biochemical response in the medullary thyroid cancer in the original primary analysis set. What you see in the left is the calcitonin response, and on the right is the CEA response, which basically shows you, again, that the RET inhibitor is going right to the source of the cancer cells and the tumor markers that they produce, and that we can sometimes even pick up a decrease in the activity of these cells long before we actually see a decrease in the size of the tumors, because initially it seems like the first activity is that the biochemical markers get shut down first, prior to when we actually can appreciate the benefit of this agent on the size of the nodules themselves. So now we'll turn our attention to differentiated thyroid cancer. Moving on to the activity of selpercatinib in RET fusion-positive thyroid cancer, when we look at the New England Journal of Medicine waterfall plot for these patients, you can see that it didn't matter what sort of histology they had, all of these patients seemed to do well, with the vast majority getting at least stable disease, some shrinkage, or sometimes even up to 100% of shrinkage of their target lesions. And this didn't seem to matter whether or not they had poorly differentiated or the more well-differentiated papillary thyroid cancer subtypes. Again, these responses were durable, maybe not quite as durable as the responses that were seen in the medullary point mutations, but they were durable, and the median duration of response has not yet been reached. And the progression-free survival also has not yet been reached. But interestingly, in both cases, half of them had been pretreated, and these patients have done quite well, and I would say have exceeded the benefit that I would have hoped for with the new agent selpercatinib. Now, a couple of really interesting points. I pointed out early on that the RET V804M Gatekeeper mutation, there was patients that had this. And what's interesting is that selpercatinib was active against this Gatekeeper mutation. Analogous mutations in other kinase domains is often associated to resistance. And what you can see here on the left is how the liver has a very, very large tumor mass that has now almost completely responded by cycle 2. So this patient who had massive infiltration of the liver not only had an incredible response, but in addition had a response in spite of the fact that they had this 804M Gatekeeper mutation. And interestingly, this patient had also been heavily pretreated as well. So this kind of complete response, which was actually documented as of 8 weeks of treatment after cycle 2, shows how well some of these patients did. And this patient remains on treatment after 20 months. thyroid cancer can sometimes go to the brain, and in the case of anaplastic thyroid cancer, it can go quite easily, but it also can be seen with differentiated thyroid cancer. So we had a patient on the study who was 73 years old with a RET fusion anaplastic thyroid cancer who had disease that had metastasized to the lung and the brain. The patient had had a prior surgery, SRS, as well as a taxane chemotherapy, and they initiated selpercatinib at the starting dose of 160 milligrams twice daily. They had a confirmed partial response by RECIST after 8 weeks of treatment. You can see here on the left how well the patient's brain lesions did in responding to the selpercatinib at baseline and then looking down at cycle 2 and cycle 10. However, from baseline to cycle 2, they had some progression of a lesion that was in their lung, but this stabilized and eventually got a little bit smaller. And this patient had a confirmed RECIST 1.1 PR at 8 weeks and remained on treatment at 14 months. Now, anyone who's treated anaplastic thyroid cancer will know that this is really a remarkable response. Now, what's really interesting, and if we look at both the RET-mutant MTC or the RET fusion-positive thyroid cancer, what we look for is what is the tolerability of these agents. In the differentiated thyroid cancer group, as well as the medullary, we look to see the proportion of grade 3 or grade 4 toxicities that are attributed to the agent. And what you can see here is that there were a handful of grade 3s that were a little bit more common. Only 12% had grade 3 hypertension, which meant that they required 2 or more antihypertensives, but extremely few grade 4. And for that reason, if you look at this and we were to compare it to either vandetanib or cabozantinib in the case of medullary thyroid cancer, or sorafenib and lenvatinib in the case of differentiated thyroid cancer, this treatment-related adverse event table really is improved when we compare it to those other agents. Now, of course, it's not exactly the same population, but this looks like a very tolerable agent. And having used this agent now for quite some time, I will say that these patients do tolerate it quite well with minimal difficulty, even in the case of the other grade 3s, most of which were actually not even related to symptoms. They were even just lab abnormalities that were picked up on sequential labs. So sometimes the patients didn't even notice some of these grade 3s. So I would say that these are patients who did really quite well, and this toxicity profile really compares favorably to all of the FDA-approved agents, both for medullary thyroid cancer and differentiated thyroid cancer. And in the libretto trial, we actually see here that these patients did very well as far as their physical function. In many times, in 20% or 18% of the patients, their physical function actually improved. When we look at their global health status, these are all self-reported. Most patients felt that their overall health status was stable, but 29% of the patients felt that their health status had improved. Again, this goes back to the fact that we were able to catch most patients and treat them before they actually had symptoms. And that's something I think we want to do in general because symptoms don't always improve, but it's definitely good to see that they were improving when people were experiencing them. And to see the breakdown of the actual symptoms patients experienced and how well they improved, this shows nicely how well diarrhea, pain, fatigue improved in patients who are treated with selpercatinib. Look at how large the blue part of these pies is. That really shows that these are people who are improving. The biggest symptom we worry about, of course, in medullary thyroid cancer is intractable diarrhea, and the responses there are great as well. And that goes along with the fact that biochemically we saw a sharp drop in the levels of calcitonin. And the calcitonin is the mechanism for the diarrhea. So we know actually that if we treat these patients with selpercatinib, not only will their actual tumor shrink, but immediately they'll have a benefit if they have diarrhea that will actually resolve or certainly become better controlled. And this is basically a summary of the proportion of patients with diarrhea and the severity based on the cycle of therapy. You can see how quickly, even between cycle 1 and by cycle 3, you had had a 50% reduction in the severity of the diarrhea events that they were happening. I can't emphasize enough how important this is to the patient, that they can see that they're benefiting from the therapy, that they're clearly knowing it because they're feeling better and having less issues with managing the diarrhea. So FDA approval of selpercatinib was given in May 8, 2020. The FDA granted accelerated approval, and for adult and pediatric patients over 12 years of age with advanced metastatic mutant medullary thyroid cancer who require systemic therapy, as well as adult and pediatric patients greater than 12 years of age with advanced or metastatic RET fusion-positive thyroid cancer who require systemic therapy, and who are radioactive iodine refractory. Of note, in the same approval, selpercatinib was also given go-ahead for RET fusion-positive non-small cell lung cancer.
On December 1, 2020, The FDA also approved pralsetinib for adult and pediatric patients 12 years of age and older with advanced or metastatic RET-mutant medullary thyroid cancer who require systemic therapy, or RET fusion-positive thyroid cancer who require systemic therapy and who are refractory to radioactive iodine.
And to follow up on the original findings, Libretto 531, which is a randomized phase 3 of Selpercatinib in treatment-naive RET medullary patients, where they're randomized between Selpercatinib or physician's choice of either cabozantinib or vandetanib, is ongoing. And the purpose of this phase 3 is to really understand how does Selpercatinib compare to the current FDA-approved agents in the first-line setting to justify whether or not this should be used first or perhaps after the other agents. The key eligibility criteria are similar, that they're medullary thyroid cancer, that they have a RET mutation, they're treatment naive, and that they're greater than 12 years old. This is an international phase 3 study. Libretto 531, which is this phase 3, has primary endpoint to compare treatment failure-free survival, which incorporates radiographic progressive disease, unacceptable toxicity, or death in patients with progressive advanced kinase inhibitor-naive RET-Mutant (MTC) that have been treated with selpercatinib versus either cabozantinib or vandetanib. In other words, if we take into account not just when people progressed on vandetanib and on cabozantinib, but also when they might have failed those agents due to unacceptable toxicity. And we want to know what that time is versus their treatment with selpercatinib to see whether or not, in addition to having good responses, it's also more tolerable in a head-to-head comparison. Then secondary endpoints included efficacy outcomes based on the RECIST 1.1 in patients with progressive advanced disease, and of course in the kinase-naive patients, and then of course, to evaluate the safety and tolerability and the tolerability of selpercatinib directly versus cabozantinib or vandetanib. So when patients are enrolled in this study, they're either randomized to selpercatinib up front or to either cabozantinib or vandetanib, which is at the choice of the investigator and the patient. So now we can turn our attention to pralsetinib as a selective RET inhibitor. Pralsetinib is a second selective RET inhibitor, and as I pointed out, is also very selective for RET. Pralsetinib has been studied in a phase 1, phase 2 study as well called the ARROW study. And this studied advanced solid tumors that had RET altered either by fusion or by point mutations. They were not allowed to have any other driver mutations, and they had an ECOG performance status of 0 or 1. And that really resulted in three main buckets. We had RET fusion positive non-small cell lung cancer, RET mutated positive medullary thyroid cancer, and RET fusion positive other cancers. So when we focus on medullary thyroid cancer, I think the most informative is to look at the results that were presented at the recent ESMO Congress for 2020. Moving to the clinical responses of pralsetinib in patients with prior cabo or prior vandetanib, you see a really nice response rate of 60%. Stable disease, in addition, was another 36%. The duration of response had not yet been met, and we're over 24 months out now with this study. And in addition, the progression-free survival, the median also has not been met. When we look at patients who had no prior systemic therapy, their overall response rate goes up to 74%, and the disease control rate is now 100%. This is interesting and, of course, expected and what we saw before, which is that patients who are treatment naive tend to do even better than the patients who were pretreated with cabozantinib or vandetanib. Again, when we look at the duration of response and the progression-free survival, medians have not been reached. We're up to 24 months in the case of progression-free survival, and the duration of responses are over 15 months at this point. So again, a very durable response. So the activity of pralsetinib in RET fusion-positive thyroid cancers is clear even in this small set. Regardless of what the binding partners were, they all seem to benefit from treatment with pralsetinib. The overall response rate was 91. That's because one of them was a poorly differentiated thyroid cancer, I think, that may not have been confirmed, although they had significant decrease in their target lesion. So 91% of patients had a partial response. Additional 9% had a stable disease for a 100% control rate. Now, what we want to look at in pralsetinib as well, which is safety. And what we saw was that most of the adverse events were low grade, which were CTCAE grade 1 or grade 2. The most frequent treatment-related AEs, greater than 50%, were anemia, increased AST, decreased white cell count, hypertension, increased ALT, hyperphosphatemia, and neutropenia. Treatment duration was up to 23.5 months with a median relative dose intensity of 96%. It's so well tolerated that very few of the patients needed dose reductions, and no patients discontinued due to treatment-related adverse events. So now we have some practical recommendations for the multidisciplinary team. And there's really two phases of our recommendations to the multidisciplinary team. The first is that we need to make sure that these patients are treated in a timely manner. And of course, we want to make sure that all attempts at a total cure have been attempted prior to assuming that the patients need systemic therapy. This includes, of course, the surgeons removing as much of the tumor as possible, then having close follow-up by the endocrinologist based on both tumor markers and ultrasounds. Pathologists will need to be proficient in actually identifying the subtypes of thyroid cancer because I think we've shown that the different subtypes will have different outcomes. And of course, all pathologists need to know the difference between a differentiated thyroid cancer and a medullary thyroid cancer. So these are what I would consider the basics, the very beginning points of treatment for the multidisciplinary team. But then once the patient has been treated, the surgery has been done, and perhaps it's been realized that the patient still has residual disease on the basis of continued positive calcitonins, it's important to continue to follow those patients. I'll point out that in the case of medullary thyroid cancer, some of those patients may actually be stable for quite some time and therefore not require treatment. Active surveillance also applies to differentiated thyroid cancer patients, although this doesn't usually happen until after they've had their radioactive iodine and have then been found to have residual disease on the basis of a positive thyroglobulin. Once we start to get into the realm of considering systemic therapy, then there's some additional information we need to know. And the most important thing for our endocrinology colleagues to know, I think, is that based on the fact that we now have very good systemic therapies that require pretty important and sometimes time-consuming genetic testing, it is important to have a timely referral from those patients at the moment that they are found to be radioactive iodine refractory and progressing, or at the time that they're found to have residual disease that's not going to be surgically amenable. These patients should be referred to an oncologist for two reasons. The first is so that genetic testing can be initiated, and in so doing, by knowing the genetics of their tumors, we actually know what are our treatment options going to be, and we can make a long-term plan. But the second reason is also important. Oncologists need to develop a relationship with those patients. And depending on whether or not they're going to get a RET inhibitor or maybe other agents such as vandetanib, cabozantinib, lenvatinib, or sorafenib, those agents require quite a bit of patient education. And that can't be done all in one visit once they immediately need to have systemic therapy. It's much better that that education happens over multiple visits. Pathologists are also an important part of the team because they will receive the orders from the oncologist to check for these panels. It would be valuable for the pathologist to not only know how to diagnose the different subtypes of thyroid cancer, but to understand that a patient with differentiated thyroid cancer should have a good fusion panel that would include all the RET as well as TRK fusion genes. This is usually found, as I said before, on a Foundation 1 heme panel, which is a little bit of a misnomer because, of course, this is not a heme malignancy. But it's the heme panel that actually has the good fusion panels for solid tumors. In addition, we also need to know that for patients with medullary thyroid cancers, that they need to have the point mutations checked, mostly by a next-generation sequencing panel. And the pathologist would be helpful if the oncologist orders the incorrect one to be able to call the oncologist directly and catch any mistakes along the way. So then the question then becomes, how do we detect these mutations and these fusions? Prior to therapy, in many patients with medullary thyroid cancer, if they're young, may have actually had some RET testing. But let's think about it a little bit. If a patient has medullary thyroid cancer and they have surgery and they're completely cured, there's really nothing else that needs to be done. What we're really talking about are patients who have residual disease. So prior to any therapy, we're going to want to know what are our treatment options. And for that reason, it's important to get recent tissue in order to test for RET alterations. And that applies whether it's differentiated or medullary thyroid cancer that hasn't been cured by basic local therapy, either surgery or radioactive iodine in the case of differentiated. We usually like to look for panel-based testing, and the reason for that is related to the fact that if we use PCR or FISH specifically just for RET or particularly for any other gene, we will waste tissue because we'll require multiple rounds of sections of the tissue in order to test for each one individually. So for that reason, it's really important to use a panel-based approach. In addition, it's very important to understand NGS RNA testing for fusions, and DNA-based testing is for point mutations. So in the case of medullary thyroid cancer, where we're looking for point mutations, we really need to make sure we have a good DNA-based panel because it's going to be a sequencing type of panel where we'll sequence the DNA and look for point mutations. When we're thinking about it in the case of differentiated thyroid cancer, it's important for us to know whether or not there's a fusion. And the best way to do this is usually testing with RNA. Now, RNA, interestingly, can last up to 2 or 3 years in a sample. DNA, and I'm talking in a paraffin-embedded sample, will last sometimes 20 years. So it's important to know that and make sure that you test a sample that's in the right age range. So if the sample you have that you want to get fusion testing on is already 10 or 15 years old, it's highly unlikely that that will work, and you might need to consider that patient for a core biopsy in order to get more fresh tissue for testing. As I said again, in the case of DNA-based testing, those can sometimes last for years, and many times sections from prior surgeries, even if they were 10 years old, can be used. So for differentiated thyroid cancer, we need to know what fusion panel we have access to that will detect all of the translocations we might be interested in. In addition to RET, there are also TRAC fusions in differentiated thyroid cancer. One example is the Foundation 1 heme panel will check for fusions in both of those genes that might be of importance. We tend to use the local ones from our own hospital at the University of Pennsylvania Center for Personal Diagnostics. It's important to actually check and make sure that the RET fusions, as well I would say as the TRAC fusions, are present on your panel so that you're going to get all of the information for all of the targeted therapies you might be considering in that setting. Now, for the case of patients with medullary thyroid cancer, it's really about sequencing panels. So those are a little bit more straightforward. In the case of Foundation 1, it's the CDX or solid tumor panel, or again, any other local panel that you would do at your institution. So what do the oncologists need to really focus on? Well, they need to know that medullary, you need to check for RET mutations. Now, most of the time when I see a patient who has a RET mutation, these patients already need systemic therapy or are going to need systemic therapy because they have metastatic disease. So because I will find all RET mutations, I don't worry about whether they're germline or somatic. I just order the somatic testing. But you have to remember that when you get the somatic testing results back, if they have a somatic mutation and they haven't previously been checked for a germline mutation, you then need to check right away for that, because half of those patients will harbor a germline mutation, and if that is positive, they will need to have a referral for genetic testing and genetic counseling. And additional members of their family may also require RET germline testing. Of course, in the cases that I have that patients harbor a RET mutation, at this point, because Selpercatinib is now FDA approved, and based on the toxicity profile, the duration of response, the depth of the responses, in my practice, we tend to give Selpercatinib in the first-line setting. What do oncologists who are looking at differentiated thyroid cancer need to know? Well, it's important that they identify not just RET fusions and TRAC fusions, but they also identify BRAF point mutations, which can be present in 50% or greater of those patients. So they need to have both a good fusion as well as a point mutation panel done when they're getting their testing. Again, you can use older tissue when you're looking for the point mutation, specifically the BRAF, but it's important to have a more recent sample when you're looking at the fusions. When we look again at what therapy we would have in the case of the patient with a RET fusion, because of the good duration of response, the good progression-free survival, and the fact that these are so well tolerated, again, my patients would end up getting probably Selpercatinib in the first-line setting, now that it's FDA approved, but then get Vandetanib or Sorafenib in the second-line setting. In my practice, we don't tend to use BRAF mutation inhibitors because I do not find that the side effect profile is that improved and the data with Lenvatinib is so compelling. So our order of therapy at this point, we tend to use RET inhibitors first, then Lenvatinib or Sorafenib, and then a BRAF inhibitor if there is a BRAF mutation. Now, sometimes BRAF inhibitors get moved up on the basis of the fact that they can't tolerate either Lenvatinib or Sorafenib. But again, these are patient-specific decisions that need to be made, and it's important that the oncologists understand the rationale for why you might use one therapy over the other. It's also really important for oncologists to know whether they're using Selpercatinib down the line, whether they're using Pralsetinib, and also whether they're using the other agents that were approved, including Lenvatinib, Sorafenib, Vandetanib, or Cabozantinib, that the success of the patient will depend on their ability to control the side effects. You do not give these agents and then expect the patient to do well and come back in 3 months. It is absolutely imperative that these patients get some sort of close follow-up, at least initially. In the case of the RET inhibitors, you might be able to space those out earlier on the basis of their tolerability. However, in Sorafenib and Lenvatinib, our patients will often come more often for the first 2 to 3 months until we really know that they're able to manage the dose is correct, and that they have good remediation strategies for any side effects that they might encounter. So it's not okay just to know that you should give these drugs. It's actually important to have some education on how to give them well. The patients will benefit from it, and you'll get the better response that you'll be hoping to obtain for each of your patients. So, in conclusion, this ends our infographic educational activity focused on RET alterations and RET targeted therapy in thyroid cancers. I hope you found the material presented here informative and useful to your practice. Thank you very much for participating.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.